Hi, everyone. My name is Angela Barton, and I've conducted my presentation on the National Patient Safety Goals in relation to nursing care centers. So what are the National Patient Safety Goals? They were established in 2002 to help accredited organizations address specific areas of concern in regard to patient safety. It was created after the report To Err Is Human was published, which outlined deplorable and avoidable safety issues that occurred within our healthcare system, and it gained national attention. Safety is an important aspect of our healthcare system, mainly because without care that is safe, it can't be of high quality. So we really need to start from a provider standpoint to ensure that they are providing care that is not causing unnecessary harm and that patients are comfortable to come to utilize our care because the safety issues that we have are not very prevalent. So who do the National Patient Safety Goals target? According to the Joint Commission, the following 8 healthcare facility types are targeted by the National Patient Safety Goals. But for the sake of this current presentation, we will be focusing on nursing care centers. Current safety issues in nursing care centers. According to the Joint Commission, the following 5 issues are targeted by the National Patient Safety Goals: patient identification, medication safety, healthcare associated infections, falls prevention, and pressure ulcer formation. Patient identification is the forefront and most important aspect, and it occurs first in the list of 5 safety issues. It's required that 2 patient identifiers are utilized when providing care, treatment, and services. Identifying residents within the facility can decrease medication and treatment errors. It's common sense to think that knowing which resident is which allows the provider to better care for them, so that way they're not mixing up treatment plans and medications. Ways to improve patient identification measures are to photograph residents upon admission, especially useful for EHRs. This is something that's utilized within my facility as we have someone go around to take photographs of the residents when they're admitted and added to the EHR file. That way the nurse can look at the photograph and the person in front of them to make sure that it's the same person. Additionally, keeping medical charts updated and fact-checking them with a supervisor and the resident themselves can make sure that we know which resident is which. And utilizing dates of birth, social security numbers, and addresses are also great forms of patient identifiers. Medication safety. So we are required to maintain and communicate accurate patient medication information, especially because giving medication to the wrong resident can result in overdose, allergic reaction, or other serious issues. So ways to improve medication safety are to utilize EHRs, keep both an electronic and a written track of medication administration per resident, utilize proper patient identification measures, and to count narcotics on med carts between shifts to make sure that they are being used for the correct residents. Healthcare associated infections. So we are required as a skilled nursing facility to comply with either the current CDC or the current World Health Organization in terms of hand hygiene guidelines. This is especially important because by frequently washing hands and keeping surfaces clean, we can minimize the risk of communicable diseases being spread throughout the facility. The most common infections found in nursing homes and nursing care centers are pneumonia, UTIs, and skin infections. But other infections and viruses also run rampant throughout nursing homes, such as the flu, and in the current age, COVID-19. Ways to minimize infections are to improve oral care, because that's been found to minimize pneumonia, implement infection control measures as required by CMS, which means to implement and appoint an infection control preventionist who is in charge of ensuring that staff are adequately washing hands and maintaining hygienic measures when cleaning residents, cleaning rooms, and other measures to keep diseases from being transmitted. And finally, testing residents for infections and communicable diseases when residents begin to display symptoms can keep them from spreading further. Falls prevention. Within my facility, reducing the risk of falls to 0 is one of the more important goals that we have. Falls typically occur when our elderly residents are left unattended and they attempt to get out of bed or use the restroom on their own. Falls lead to unnecessary and avoidable injury, including fractures, injuries, and other types of deaths. They could be sent out to hospitals. And most falls really tend to occur with residents who suffer from dementia, Alzheimer's, or vision issues. Ways to decrease falls: monitoring residents who are cognitively or visually impaired, implementing in-services and educations for staff, and keeping residents mobile, specifically those that are able to ambulate, to strengthen their muscles to make sure that their legs aren't giving out when they're trying to walk. And finally, pressure ulcer formation. The current requirement is to assess and periodically reassess each patient's risk for developing a pressure ulcer and to take action to address any identified risks. Pressure ulcers really tend to form when residents are lying down or sitting down for very long periods of time. Especially, they tend to occur on the backside, on the legs, on the side of the body, really whatever point of the resident's body is most in contact with the bed that they're lying on. So ways to minimize the formation of pressure ulcers is to perform risk assessments to determine which residents are most at risk of developing the ulcers, and also skin assessments. Within my facility, we do have an assistant director of nursing who is appointed as the person to perform the risk assessments, the skin assessments, and the wound rounds. So she will check each resident from tip of the toe to the top of the head to make sure that when they're admitted and throughout their stay at our facility, that they're not forming pressure ulcers. A second aspect to minimize formation is to keep residents mobile and repositioned. This is so that way different parts of the body are used and put pressure upon while they're laying down to minimize more prevalent points of contact from forming the ulcers. And finally, ensuring skin is cleaned thoroughly and dried between washing can help also to minimize these ulcers. So key steps in the performance improvement plan. For the current improvement plan, I have outlined a 1-year timeline with 4 quarterly check-ins with team members to evaluate progress and make changes. Step 1. This first step is to identify the issue present within the facility as outlined by the National Patient Safety Goals. So the issue in step 1 is to identify that there are issues with patient identification and medication administration, along with falls prevention, pressure ulcers, and other types of infections. Second step is to identify employees and management team members responsible for ensuring the correction of the issue. So in this case, most of the time we would want to be looking at the clinical staff who are caring for the residents on a day-to-day basis. Third is to identify the goals and the objectives that the team members should meet, along with a timeline for improvement. So the timeline, as I mentioned, is 1 year with 4 quarterly check-ins, and the goals are to minimize or even eliminate the rates of these 5 topics from occurring. Finally, the fourth step is to evaluate the performance of the team involved and identify areas for improvement. So of course, we want to look to see how we've performed and then measure those results accordingly. The following few slides are more in-depth explanations for each topic that for the sake of time we won't go through, but we will just breeze so that you can see it. Measuring the results of the performance improvement plan is essentially step 4.5 to 5. So we want to look to see how we performed and measure those results to improve for the future. Team members should be reporting to their supervisors, who typically would then be reporting to the director of nursing, who is then collaborating with a nursing home administrator, who is our healthcare administrator in this scenario, within the designated timelines determined. Changes should be evaluated regarding rates of safety issues that have occurred within those 5 topics within the 1-year timeline. We want to look to see if they improved, if nothing changed, or if things got worse, and then take that information, see where we were successful, and try to apply that for the future and fix the mistakes that were made. It's important to ask questions to the staff involved. So, did the rates of poor safety increase or decrease? For which residents was there an issue? Was there an underlying reason for why different residents experienced a problem? What successes were experienced? And was there an extenuating circumstance that led to an error in safety? At the conclusion of the timeline of the performance improvement plan, the number of falls, incorrect patient identification, improper medication administration, healthcare illnesses, and pressure ulcer formation should all have decreased. If that does not happen, we would want to review the mistakes again and utilize the successes to improve the following year's performance plan. Implications of the healthcare administrator. So as previously stated, the healthcare administrator in this scenario is the nursing home administrator. They're also synonymously referred to as the executive director. Nursing home administrators are involved while their facilities are undergoing state surveys each year, in which these five topics are reviewed and evaluated amongst several other concerns. Therefore, the administrator must be aware of the prevalence of the issues within their facility and determine ways to correct them. They would want to appoint a director of nursing who is knowledgeable and concerned with patient safety. Additionally, they would also want to appoint an infection control preventionist as required by CMS to make sure that hand hygiene guidelines and other safe transmissions of diseases are minimized. They'd want to prepare a team of individuals responsible for in-servicing and educating staff on methods to maintain resident safety. Produce methods to avoid falls, medication errors, improper patient identification, formation of pressure ulcers, and other healthcare infections by working closely with the nursing department. This to me is the most crucial method, and it's been conducted well within my own facility. It's really crucial for the administrative team and the clinical staff to have a good relationship to make sure that we're making the necessary changes, evaluating what could be changed for the future, and overall ensuring that patients are safe. Next, they'd want to educate themselves on the penalties associated with improper safety measures within their facilities, because penalties do occur when surveys go poorly. And lastly, they'd want to produce solutions post-survey if surveyors discover gaps in safety initiatives. Here are my references that I utilized for the presentation. I hope you enjoyed it, and I hope that you learned something from it as well. Thank you.